Hello friends, welcome back to my YouTube channel. This video is my 20th notebook for Neet PG exam, starting with dermatology. Atopic dermatitis or atopic eczema, it is a chronic relapsing inflammatory condition. It is an erythematous macules, papules as well as vesicles. There will be family history of bronchial asthma. Pruritic itchy lesions at the flexural site is seen here. There will be scratch marks as well as excoriations. Atopic dermatitis or atopic eczema, it is a genetic mutation of FLG gene. There will be decreased filaggrin production. Purpura, it is a primary skin lesion. Purpura is seen in vasculitis, vitamin C deficiency, thrombocytopenia. Secondary skin lesions include IAC. What is IAC? Induration, atrophy, crust. Next is primary lesions of the skin include papule, macule, pustule, purpura, patch, plaque, wheal, vesicle, bulla, nodule. Secondary lesions of the skin include cordis leaf sucks, LEAF leaf, L for lichenification, E for erosion or excoriation, A for atrophy, F for fissure, that is leaf. Leaf sucks is the cord. So next about the sucks, S for scale, U for ulcer, C for crust, K for kind of hard to feel, induration, S for scar. So leaf sucks is the code for secondary lesions of skin. I will again repeat the secondary lesions of skin. They are lichenification, erosion or excoriation, atrophy, fissure, scale, ulcer, crust, kind of hard to feel, induration, scar. Next I am going to tell about scleroderma. It is not scleroderma. I am going to tell about scleroderma. Scleroderma, there will be increase in type 1 collagen synthesis by dysfunctional fibroblast. So there will be fibroblast proliferation. Hand and feet are spared here. Verruca vulgaris and as well as common wart. Verruca vulgaris as well as common wart is caused by human papillomavirus 2. Pseudocopner phenomenon is seen here. Next is about cutis marmorata. Cutis marmorata is about the cold temperature. Persistent cutis marmorata is seen in trisomy 18 as well as trisomy 21. Varicella zoster virus, there will be dormant dorsal root ganglion. Next is hyperpigmented skin on shoulders and hypertrichosis is seen in Becker's nevus. It is an epidermal melanocytic nevus. There will be aggregation of melanocyte clusters in epidermis. It is hairy. There will be increased sensitivity to androgen. Becker's nevus triad includes hyperpigmentation, hypertrichosis as well as acne. Hair dye consists of p-phenylenediamine which causes contact dermatitis. Hair dye also causes acute edema, intense pruritus followed by desquamation. Next question is painless ulcer in genital area which is associated with non-tender inguinal lymph nodes. Diagnosis is primary syphilis. Incubation period is 9 to 90 days. 90 days. Latent syphilis, there will be no clinical features but serological testing will be positive. Late syphilis, also known as tertiary syphilis, here we can see punched out ulcers known as gummas. For all stage of syphilis, treatment is parenteral penicillin G. Treponema pallidum, we can see corkscrew morphology as well as motility. Secondary syphilis presents as macular rash, here we can see moth-eaten alopecia. Serological test for syphilis includes VDRL as well as rapid plasma reagent. Congenital melanocytic nevus is associated with malignant melanoma. Complications of congenital melanocytic nevus consist of intraparenchymal melanosis, malignant melanoma, rhabdomyosarcoma. Sturge-Weber syndrome is associated with glaucoma. In Sturge-Weber syndrome, we use port wine staining. Madura mycetoma, it is caused by both bacteria as well as fungi. Mode of Madura mycetoma infection is traumatic. Eumycetoma treatment is ketoconazole as well as miconazole. Actinomycetoma treatment is dapsone rifampicin. Multiple anogenital wart, in biopsy we can see squamous atypia. It is of high risk type. Multiple anogenital wart is caused by human papilloma virus type 16 as well as 18. Most common type of multiple anogenital wart is squamous cell carcinoma. Risk factor for anogenital wart is OCP as well as pregnancy. Multiple anogenital wart is diagnosed by colposcopy. In histopathological evaluation, we can see coelocytes. Next is about chromoblastomycosis. It is also known as Fonseca. Mode of chromoblastomycosis is traumatic. It is mainly seen in barefoot farmers. Cauliflower-like cutaneous nodules on feet and lower legs are the presentation. There will be irregular round dark brown septae, which is known as sclerotic bodies, which is also known as copper penny bodies. Treatment includes itraconazole 100 to 200 mg daily as well as terbinafine 250 mg daily. Next is about blastomycosis. Blastomycosis is caused by blastomyces dermatitidis. It causes acute LRTI. Microscopic evaluation, we can see broad-based budding yeast cells. Addison's disease is also known as primary adrenal insufficiency. Here there will be stimulation or production of melanocytes by increased ACTH. Next topic is psoriasis. Psoriasis consists of punctate pitting, oil drop sign, subungual hyperkeratosis, splinter hemorrhages, distal onycholysis, ring of Voronov, silvery white scales, Auspitz sign, Koebner or isomorphic phenomenon. All these points mainly we should think about psoriasis. Treatment for psoriasis include steroids, retinoids, vitamin D, emollients, phototherapy, oral methotrexate, acitretin, cyclosporin. Koebner or isomorphic phenomenon, it is also seen in lichen planus. Next topic is alopecia areata. Alopecia areata, there will be stippled pitting of nails, roughening of nail plate as well as atrophic dystrophy. In atopic dermatitis, there will be coarse pitting as well as ridging. Telogen effluvium, there is non-scarring alopecia. Causes of non-scarring alopecia include tinea capitis. Hormonal cause include hypothyroidism, androgenetic alopecia, alopecia areata, anagen effluvium, telogen effluvium, trichotillomania, secondary syphilis or moth-eaten alopecia, SLE, deficiency of zinc as well as iron. Next is about the causes of scarring alopecia. Scleroderma or N-Coupe de Sabry or linear scalp morphia, Favus and Kirion, folliculitis decalvans, lichen planopilaris, lupus vulgaris, lupus erythematosus, that is DLE, discoid lupus erythematosus, as well as pseudopelade of Brock. These are the causes of scarring alopecia. Next topic is about lupus vulgaris. It is the most common cutaneous TB in India. On dioscopy, lupus vulgaris presents as apple jelly nodules. These have serpiginous edges as well as central scarring, and it shows an annular plaque-like resemblance. Central atrophy can be seen here. Site is mainly on face as well as buttocks. Treatment for lupus vulgaris include anti-tubercular therapy. Isomorphic phenomenon or Koebner's phenomenon is associated with plaque psoriasis. Herpes labialis or cold sore treatment is oral acyclovir 200 mg as well as 5% topical acyclovir. Nikolsky sign is positive in pemphigus as well as Staphylococcus scalded skin syndrome. Ichthyosis vulgaris is an autosomal dominant condition. There is mutation in filaggrin gene. Amorolfin is used in the treatment of onychomycosis. Amorolfin is a 5% nail lacquer which belongs to morpholins. Next case is mild painful swelling over the scalp for 3 months. There is a dog at home. Here in the patient we can see boggy inflammatory mass, thick crusting as well as matting of hair. Diagnosis is carrion. It is a severe inflammatory type of tinea capitis. Variants of tinea capitis include endothrix, ectothrix, carrion as well as favus. Endothrix is black dots around swollen hair shaft. Endothrix is caused by tinea tonsurens, tinea violacum. Next is ectothrix. It is caused by Microsporum odini. Here we can see grey coated broken hairs. Next is carrion. It is an inflammatory alopecia which is caused by tinea verrucosum as well as tinea mendegrophytes. Here we can see thick crusting matting of hair with pus as well as sinus formation. Next is favus. It is also an inflammatory alopecia. It is caused by tinea schonlini. Here we can see scutula, that is cup-shaped crust. Treatment of tinea capitis include itraconazole 2 to 4 mg per kg per day for 4 to 6 weeks as well as terbinafine. Terbinafine, the dose is according to the weight. That means less than 10 kg we give 62.5 mg daily for 4 weeks. 10 to 20 kg for patient we give 125 mg daily for 4 weeks, and in a patient more than 20 kg we give 250 mg daily for 4 weeks. So basically treatment for tinea capitis include terbinafine as well as itraconazole. Next case is patient has night blindness which is due to the deficiency of vitamin A. Along with it, patient has multiple keratotic papules on elbows, and also patient has a taut skin appearance. The diagnosis is phrenoderma. Here there is a group of papules with central keratotic plug. Site of phrenoderma or taut skin is elbow or knee. Treatment is correction of poor diet, and also multivitamin containing vitamin A should be given. Next case is diarrhea disease. Diarrhea disease is an autosomal dominant condition. It is due to ATP2A2 gene mutation. In diarrhea disease we can see acantholysis as well as dyskeratosis. There is blistering which is seen in suprabasal epidermis, and also in nails we can see V-shaped nicks. Next case is pemphigus vulgaris. In pemphigus vulgaris we can see flaccid bulla skin which is easy to rupture. On biopsy we can see suprabasal split. Antibody against desmoglin 3 as well as IgG antibodies are seen in pemphigus vulgaris. Fishnet appearance is seen in the immunofluorescence assay. Treatment for pemphigus vulgaris is steroids, azathioprine, mycophenolate mofetil as well as rituximab. Pemphigus foliaceus, it is antibody against desmoglin 1, and also we can see subcorneal blisters on pemphigus foliaceus. In pemphigus vegetans we can see eosinophilic microabscess, and here there is verrucous vegetating plaques as well as pustules on groin, axilla as well as flexural surfaces. Content of Binti leucoderma is PTBP, that is para-tertiary butyl phenol. Treatment of choice for trichomoniasis is metronidazole 2 mg single oral dose or denidazole. Erythema multiforme following herpes simplex virus infection is classic acral iris or target lesions. Next case is in a patient with type 1 lepra reaction, there will be worsening of lesion as well as nerve problem, and this is a patient on MDT. So what is the next thing we should do? We should continue MDT and start systemic steroids. Next is about alopecia areata. In alopecia areata, we can see fine stippled pitting of nails as well as exclamation mark hair. Next topic is leprosy. Leprosy mainly affects the facial nerve as well as posterior tibial nerve, followed by ulnar nerve, median nerve as well as lateral popliteal nerves. Leprosy is caused by Mycobacterium leprae. In leprosy, there are two reactions. They are type 1 reaction as well as type 2 reaction. In type 1 reaction, we can see BT, BB, BL, and it is a type 4 hypersensitivity reaction. Type 1 reaction is also known as reversal or upgrading. Next is type 2 reaction. LL more than BL is seen here. It is type 3 hypersensitivity reaction. Type 2 reaction is also known as erythema nodosum leprosum. In leprosy, we mainly see TT, BT, BB, BL as well as LL. So, in TT, we can see saucer right side up lesion dermal tuberculoid granulomas. In BT, we can see pseudopodia or satellite lesions. Here we can see Gren's clear zone in the upper papillary dermis. Next is about BB. BB consists of Swiss cheese or inverted saucer or punched out appearance. We can also see cut onion appearance. In BL also we can see the same features as I told in the above BB. Next is about LL, that is lepromatous leprosy. Here we can see glove and stocking anesthesia, Gren's zone, expansive and loose granulomas, virchow cells as well as lepra cells. According to WHO, multi-drug therapy, that is MDT, in an adult is rifampicin 600 mg once a month plus clofazimine 300 mg once a month and clofazimine 50 mg daily, and also dapsone 100 mg daily. Multibacillary means it is for 12 months, and for posibacillary it is for 6 months. Next case is a patient on anti-PD-1 immunotherapy, that is nivolumab, comes with pruritus, eczema and urticarial rashes. Histopathological examination reveals a subepidermal blister. The direct immunofluorescence of the lesion showed linear C3 and IgG on the basement membrane. Diagnosis is bullous pemphigoid. Next case is 24-year-old young male presented with asymptomatic scaly lesions over back, symmetrical in distribution. There is a central detachment as well as peripheral attachment of the scales, which shows colarity scales, and the lesion is in Christmas tree pattern suggestive of pityriasis rosea. Pityriasis rosea is also known as pityriasis circinata or roseola annulata, which is an acute self-limiting papillosquamous disorder. Clinical features include herald patch, which is a large and conspicuous eruptions on the thigh, upper arm, trunk or neck covered by fine scales. And also here we can see prodrome of sore throat, GI disturbance, fever or arthralgia. Next is about the Woods lamp examination. By Woods lamp examination, coral red fluorescence is seen in erythrasma, yellow fluorescence is seen in pityriasis versicolor, blue fluorescence is seen in tinea capitis, milky white fluorescence is seen in vitiligo. Next case is a farmer from Tamil Nadu presents with fever, body ache and cough for 3 days. Lab studies showed thrombocytopenia. On examination, we can see a black lesion, that is an eschar at the bite site, along with the positive IgM scrub typhus caused by Orientia susugamoshi, which is transmitted by trombiculid mite. So this is a case of scrub typhus which is caused by Orientia susugamoshi. Management of scrub typhus includes doxycycline as well as azithromycin. Next case is an overweight 12-year-old girl has blackish discoloration on her neck. This is known as acanthosis nigricans, which is strongly associated with insulin resistance or hyperinsulinemia. Acanthosis nigricans is a darkening of the skin of the intertrigonous area. A middle-aged Indian man came to OPD with central ulcer with raised borders and rolled out edges, which is rodent ulcer, suggestive of basal cell carcinoma. It is a slow-growing malignant tumor with locally invasive characteristic. It affects the pilosebaceous skin. Ultraviolet radiation exposure is the strongest predisposing factor. Sites near the eye, nose, and ear and size more than 2 cm are considered to be high risk. Management is by Mohs microscopic surgery, that is MOHS, Mohs microscopic surgery. Non-surgical treatment include topical 5-fluorouracil and imiquimod. Metastasis is extremely rare. Next is direct immunofluorescence in pemphigus vulgaris shows intercellular deposition of immune complexes giving a chicken wire or fishnet pattern appearance. Row of tombstone appearance is seen in pemphigus vulgaris. The case is a patient presents with vesicles and oral lesions. Histopathological examination shows suprabasal split. The row of tombstone appearance is seen in pemphigus vulgaris. Next case is a 10-year-old boy presents with fever, joint pain and a lesion over his hand showing erythematous papules over dorsal metacarpophalangeal and interphalangeal joints, which is known as Gottron's papules, which is a characteristic skin lesion seen in dermatomyositis. Dermatomyositis, the characteristic other skin manifestations include heliotrope rash, Gottron's papules, Gottron sign, V sign, shoal sign, nail bed telangiectasis. Here there is diabetes mellitus associated with interstitial lung disease and also internal malignancies, mainly adenocarcinomas. Lab investigation for dermatomyositis include elevated serum creatine kinase and anti-nuclear antibodies. Histology will show perivesicular atrophy. Immunohistochemical staining will show myxovirus resistance protein A. Treatment of dermatomyositis include immunotherapy with high-dose glucocorticoids as first-line drug and methotrexate as second-line drug. Triple therapy with intravenous immunoglobulin or rituximab may be required. Next is a 12 weeks pregnant woman who is already on multi-drug therapy for leprosy presents with type 2 lepra reaction. What is the treatment of choice for this patient? Continue MDT and add oral steroids. Chemoprophylaxis for leprosy should be given to contact of age more than 2 years, contact for more than 20 hours per week, and living with a patient with leprosy for more than 6 months. In pityriasis versicolor, we can see powdery, briny, fine scales. In pemphigus foliaceus, we can see leaf-like scales. In seborrheic dermatitis, we can see yellow or greasy scales. In psoriasis, we can see silvery or mica-like scales. In ichthyosis vulgaris, we can see large and polygonal fish-like scales. In pityriasis rosea, we can see fine, peripherally attached and centrally detached collarate scales. Next case is a 60-year-old patient presents with the lesion, that is unilateral red grouped vesicles in a single dermatome associated with crawling sensation. He also describes having sensation of spiders crawling in the area of the lesion when he woke up. Diagnosis is herpes zoster infection. Next is a 60-year-old diabetic female patient presents with progressive skin lesions showing a central ulcer with raised borders and rolled out edges, that is rodent ulcer, suggestive of basal cell carcinoma. A diabetic patient presents with brown patches in axilla suggestive of erythrasma. Coral red fluorescence under Wood's lamp is seen in erythrasma. Alopecia areata, telogen effluvium and androgenic alopecia. These three are the causes of non-scarring alopecia. Now about the management of psoriasis. Using PUVA for long term increases the risk of skin cancer. Cyclosporin is effective in psoriasis but it is highly nephrotoxic. Methotrexate is abortifacient. Acitretin it causes mucositis as well as it is a teratogenic drug. Skin manifestations caused by the drug administered for amoebic dysentery are due to fixed drug eruption. Next case is 40-year-old man presents with erythematous painful lesions on the trunk and face, joint pain and glove and stocking pattern of anesthesia. Investigations used for leprosy include nerve examination, skin biopsy, slit skin smear. Next is a patient came to OPD with skin manifestation that is suggestive of systemic sclerosis. The skin manifestation was salt and pepper appearance. Systemic sclerosis is an autoimmune disease. It is associated with disability and mortality. Thickened and indurated skin called scleroderma. It is the hallmark of systemic sclerosis. 60-year-old patient showed purplish itchy flat-topped lesion on her shins for past 3 months. Patient gives history of chewing tobacco for 20 years. She occasionally smokes and drinks alcohol. On examination, fine white lacework in buccal mucosa, which is Wickham's stria, is seen. Diagnosis is lichen planus. First line of treatment for lichen planus include potent topical corticosteroids, which include clobetasol propionate ointment 0.05%. Inguinal bubo is caused by Haemophilus ducreyi. It is a feature of chancroid which is due to regional lymph node involvement. Next case is a young female patient had bacterial vaginosis. The features of bacterial vaginosis include fishy vaginal discharge, no itching, dysuria and dyspareunia present. Amsel's criteria seen here. Gardnerella vaginalis is also known as bacterial vaginosis. It is not a sexually transmitted disease. Clue cells are seen here. Treatment for bacterial vaginosis include oral metronidazole 500 mg twice daily for 7 days or oral clindamycin 300 mg twice daily for 7 days. On Woodlamp examination, coral pink fluorescence in groin is seen in erythrasma. Coral pink fluorescence, it is due to porphyrins. Corynebacterium minutissimum causes erythrasma. Here there is conversion of aminolevulonic acid to protoporphyrin. Patient with lichen planus shows colloid bodies. Portriose microabscess causes mycosis fungoides. Monroe microabscess causes psoriasis. Michaelis Guttman bodies are seen in malacoplicia. In basal cell carcinoma, we can see a nodule, central ulceration with pearly surface, and also it is associated with telangiectasia. In squamous cell carcinoma, we can see ulcer with thickened margins, keratosis as well as papillomatosis. Bulge bluish lumps which is swollen veins in anal area, it is known as hemorrhoids. Next case is a patient who has hypopigmented lesions on his back. On examination, complete loss of fine touch and temperature sensation over lesion is seen. Diagnosis is leprosy or Hansen's disease, which is caused by Mycobacterium leprae. Next case is a female patient who has asymmetric lesion and irregular border, black or brownish pigmentation. It is known as malignant melanoma, more than 6 mm pigmented lesion along with vascularization. Next case is a bulge bluish lump, swollen veins in anal area. It is known as hemorrhoids. Grading of hemorrhoids consists of grade 1 to grade 4. Grade 1 is only bleeding. Grade 2 is bleeding plus protrusion with spontaneous reduction. Grade 3 bleeding plus protrusion which requires manual reduction. Grade 4 includes bleeding plus prolapse that cannot be reduced. Next is about tinea corporis or ringworm infection. Tinea corporis or ringworm infection, it is caused by Trichophyton rubrum. Stratum corneum layer is seen in trunk and limbs. Terbinafine is given from topical ointment to oral. Itraconazole is also changed from topical ointment to oral. Griseofulvin is given as oral. Next case is a patient who has joint pain which increases in early morning when he wakes up and decreases with activity. Examination showed nail pitting, yellowish discoloration of nails, and inflammation of distal interphalangeal joints. Here the patient has psoriatic arthritis which shows silvery scales. Seronegative spondyloarthropathy is seen here. HLA-B27 is present. X-ray for psoriatic arthritis shows pencil in cup deformity as well as ray deformity. Nail psoriasis, the features are polish. Polish is the code for nail psoriasis. P for pitting, O for oil drop sign or onycholysis, L for leukonychia, I for irregular pitting pattern, S for splinter hemorrhage, H for hyperkeratosis, that is subungual hyperkeratosis. Next case is a female patient few weeks ago came to OP with itchy skin rashes, and at that time she was given an ointment which relieved itching. After few days of stopping that ointment application, she again came to OP with same complaints. So this is an atypical lesion of tinea, that is it is a fungal reaction diagnosed as tinea incognito. So the ointment she was given which relieved her itching was typical corticosteroid. Here again what should we do to this patient is we should treat her by giving oral terbinafine or itraconazole. Next is about novel drugs. Novel drugs are given for the treatment for acne. Novel drugs are the drugs that target both retinoic acid receptors, that is beta and gamma. Example for novel drugs include adapalene, tazarotene as well as tretinoin. Next case is 18-year-old female. She came with acne. The primary stage for acne is known as comedones. On acne assessment, what is the two investigations we do is Leeds photometric grading scale as well as CASS. What is CASS? Comprehensive Acne Severity System. Next question is 50-year-old female patient, known case of ovarian cancer. She has difficulty in activities like climbing stairs, getting up from chair, combing hair. The diagnosis is dermatomyositis. In patient, there will be upper eyelid lilac erythema or heliotrope rash. Proximal myopathy with rash in elderly female with history of internal malignancy, also suggestive of dermatomyositis. Next question is, a baby came to OP with left upper lid lesion as well as a lesion in the periocular area. It was capillary hemangioma. Most common tumor in the orbit as well as periorbital area in childhood is capillary hemangioma. Next question is, 26-year-old male came with erythematous plaques covered with silvery scales over extensor surfaces of both arms. Punctate pitting was noted on examining the nails. The diagnosis is psoriasis. Next question, patient presented with itchy lesions, purple, pruritic, polygonal, papules, planar, flat-topped, associated with hepatitis C. The diagnosis is lichen planus. In lichen planus, we can see Wickham's striae, epidermal acanthosis, colloid bodies. In lichen planus, we can see dorsal nail pterygium, which is the most specific nail change, slight thinning of nail plate, which is the most frequent nail change, pup tent sign, trichonychia, subungual hyperkeratosis and onycholysis, longitudinal melanechia. Next is side effect most commonly with isotretinoin is embryopathy or developmental disease of an embryo. Isotretinoin, it is also known as 13-cis-retinoic acid, which is vitamin A derivative. It is highly teratogenic. Next question, lithium is associated with Epstein's anomaly. Valproic acid is associated with neural tube defect in fetus. Tetracycline is associated with yellowish discoloration in deciduous teeth when used after 25 weeks of gestation. Next question, patient had lesion on right knee as an effusion, dactylitis in multiple digits, sharply demarcated red papulosquamous lesions on both knees, and later developed arthritis also. Diagnosis is psoriatic arthritis. Treatment includes methotrexate and apremilast. These are the first line drugs. Next case is 7-year-old intellectually disabled boy who had large warty crust on trunk, hands, feet, severe fissuring plus scaling of skin present over soles. The diagnosis include Norwegian scabies or human crusted scabies, which is hyperkeratotic scabies. Diagnosis is scraping steaming with mites and eggs. Next question is causative agent for acne fulminans include Propionibacterium, which shows increased testosterone levels. Next is 30-year-old pregnant female presents to dermatology OPD. The lesion here is chloasma or mask of pregnancy, which is mainly seen in third trimester of pregnancy. Same facial melanosis in non-pregnant women is known as melasma, which is seen in women on OCP. Chloasma is self-resolving after pregnancy. Melasma is more chronic. It is treated with Klickmann's triple combination, that is topical hydroquinone plus tretinoin plus corticosteroid compound cream. And the other treatment methods for melasma are hydroquinone, which reduces tyrosinase activity, kojic acid, which is an tyrosinase inhibitor, and chemical peels. Next is about Koebner's phenomenon, which is also known as isomorphic response. It is seen in DLE, vitiligo, psoriasis, lichen planus, necrobiosis lipoidica, Darier's disease, lichen nitidis. Scattered drop-like papules and plaques is suggestive of guttate psoriasis, which is caused by streptococcus. 2 to 10 millimeter papules are seen here. Next is sharply demarcated hypopigmented macules into patches over trunk is known as tinea versicolor or pityriasis versicolor. On Wood's lamp examination, this condition is diagnosed. Lesions show pale yellow fluorescence on Wood's lamp. It is a hypopigmented or hyperpigmented macules and patches which produces fine scales. Site is upper trunk. Next case is scattered drop-like papules and plaques suggestive of guttate psoriasis. It is caused by streptococcal infection, which is 2 to 10 millimeter papules. Next case is 26-year-old male patient shows a skin lesion, that is plaque psoriasis. Histopathological evaluation of psoriasis include multiple neutrophilic foci in parakeratotic stratum corneum, that is Monro's microabscess, as well as spongiform neutrophils in spinous layer of epidermis, that is spongiform pustules of Kogoj. Next is a 40-year-old male patient gives a history of rash after he took NSAIDs for his knee pain. He reported that he developed same rash in same location 6 months ago when he took the same drug for back pain. Diagnosis is fixed drug eruption. It is one of the most common drug induced exanthemas. Drug hypersensitivity causes rash, anaphylaxis as well as serum sickness. Post-inflammatory hyperpigmentation example includes acne vulgaris, atopic dermatitis, impetigo. Pathognomic finding in psoriasis include subungual oil drop sign or salmon patch. Koebner's phenomenon or isomorphic response is development of lesions in previous normal skin subjected to trauma. If the same response is seen from spread of an infective agent like molluscum contagiosum or viral warts, it is pseudo-Koebner's phenomenon. Next case is lymphatic filariasis. About lymphatic filariasis, it is also known as elephantiasis, which is caused by Wuchereria bancrofti or Brugge malai. It is delayed sequelae to repeated lymphangitis, obstruction, and also lymphedema. Repeated leakage of lymph into tissues result in lymphedema, which causes elephantiasis. Microfilaria or Wuchereria bancrofti shows a pointed tail that is free of nuclei. DEC provocation test demonstrates microfilaria during the day. Drug of choice is diethyl carbamazine. A 22-year-old college student presented with small depigmented lesions over 2 years now. Diagnosis is vitiligo. Pathological basis of vitiligo is loss of melanocytes. Common form of localized depigmentation is seen in vitiligo. Milky white sharply demarcated macules are seen on Wood's lamp. Acquired condition includes autoimmune destruction of DOPA positive melanocytes in basal layer of epidermis. Condyloma acuminata, which is also known as venereal wart, it is a sexually transmitted disease. It is caused by human papilloma virus 6 or 11. It is verrucous, exophytic cauliflower-like growth seen over vulval skin, perineum, perianal region. It is a non-tender lesion. Treatment for condyloma acuminata include local application of podophyllin 25% in alcohol or podophyllin 20% in tincture benzoin for 6 hours daily. Next is podophylox 0.5% solution and also intralesional injection of interferon. Vaccination includes Cervarix at 0, 1 and 6 months. Gardasil is given at 0, 2 and 6 months. Next is a farmer came to OPD with swelling over his palm. Few months back he got injured with thorn. The diagnosis is implantation dermoid due to traumatic injury. Histopathological evaluation shows inclusion epidermoid cyst lined with stratified squamous epithelium with granular cell layer, and it is filled with eosinophilic lamellated keratinous material. Surgical treatment is done for symptomatic cyst, that means if it is interfering with the hand function, in which complete excision is done with regional anesthesia under pneumatic tourniquet. Dermoid cyst is a firm, painless subcutaneous nodules. Dermoid cysts consist of 4 types. First is sequestration dermoid. Here the sequestration of epithelium during embryological development is seen. Next is tubulodermoid. There is accumulation of secretions from ectodermal tube or duct. Third is implantation dermoid. There is implantation of epidermis due to trauma. Fourth is teratomatous dermoid. All 3 germ layers are seen here. Ectoderm, mesoderm and endoderm is seen in teratomatous dermoid. Next case is a farmer whose foot is swollen and multiple sinus. It is a case of mycetoma caused by eumycetoma. 35-year-old male patient complains of hair loss. Examination findings showed circumscribed hairless smooth patch. Short, easily broken hairs, also known as exclamation mark hair, is seen at the margin of bald patch. Diagnosis is alopecia areata. Yellow dots are seen on dermoscopy. 30-year-old female patient has an early lesion in oral cavity and also in genitals. Proximal nail fold has extended onto nail bed. Most likely diagnosis is lichen planus. Patient has mucous membrane changes as well as pterygium of nail. Auspitz sign is seen in psoriasis vulgaris. Auspitz sign includes pinpoint bleeding, elongated vessels in dermal papillae together with thinning of suprapapillary epidermis. Gruttage, wax candle scales, thin membrane known as bulky membrane is seen in psoriasis. Next is young man with leg lesion, which is painful lesion. Edges are well demarcated and borders are raised. Complains of blisters over his body. He is otherwise normal and does not have any other disease. Infection is caused by group A streptococcus. Edge is raised. Presence of erythematous skin lesion with well demarcated borders. Diagnosis is erysipelas. Here we can see erythema, heat, pain, swelling, pain or tenderness. Most common site includes leg followed by face. Ear involvement is Millian's ear sign. Treatment for erysipelas include flucloxacillin, clarithromycin, clindamycin as well as benzyl penicillin. 40-year-old female patient complains of pain in her fingernail. On examination, there is red with erythema on nail fold. Diagnosis is acute paronychia, which is caused by Staphylococcus aureus. Chronic paronychia is caused by Candida species. Next case is sexually active male. He has warts on his penis. Similar lesions are also present near the anal canal. Diagnosis is condyloma acuminata. It is caused by human papilloma virus 6 and 11. Giant anogenital warts, which is also known as buccal Lowenstein tumor, is also seen in condyloma acuminata. Next case is a girl. She had history of severe sunburns. After just few minutes in the sun, she has severe freckling in the sun exposed areas. Diagnosis is xeroderma pigmentosa, which is characterized by defective nucleotide excision repair. Xeroderma pigmentosa is an autosomal recessive disease. It is mainly defective DNA repair which causes cellular hypersensitivity to UV radiation.